Hello everyone. My name is my name is Danish. What we are doing is we have taken a very new, different direction. We are going to be a little bit chill. We're not going to be so stressed about how things turn out to be. What we are going to do is we're just gonna read through things and see if they make sense. Previously on this channel, I tried to be very this is a good emoji. I like this one. Previously on this channel, I tried to be quite, how do you say it? You know, very like refined, and I was making sure that, I just kept doing things the right way. Which often, oh, by the way, that is my water filter. That is where I did my water from. And like things were a bit tipsy. Now, you might be wondering, why is this guy not talking directly? So the thing is here, what I'm thinking I'm gonna do is I'm just gonna give you all the stuff on the screen, and I'll just go leave. No, I'm just kidding. I'll just read it off the screen, which doesn't make much sense, but I'll try to be explaining. I'll try to be more explanative of things. It's just so that like I do things instead of like the channel being empty. So what is hypersensitivity? Hypersensitivity is something like being sensitive is like something affects you, then and you respond, you're sensitive. Hypersensitivity is when you respond to the things which are usually things that you're not supposed to respond to, right? So it's an exaggerated or inappropriate immune response to harmless antigens, leading to tissue damage or disease. These harmless antigens can come from the body or from outside the cell, or foreign particles like that. So there is this thing called the gel, and imagine it turns out to be pronounced as gel. I'll be so embarrassed. And Coombs classification. So there are basically four types: type 1 to 4. There is a little sweet mnemonic for it. It's called acid. Acid is like this. So by acid, the A stands for anaphylactic. So an anaphylactic, how I like to remember anaphylaxis is A E I owe you. I don't know if that makes any sense. So AE. So it's performed by IgE antibody. Yeah, this leads to mast cell degranulation, and therefore this type of the reaction is immediate, right? It's involved with IgE. Little another mnemonic I got edema from allergy. EA. Yeah. So C, acid. C. What is C? Cytotoxic. Cytotoxic is again C for C, cell-bound antigen, which leads to direct cell destruction, right? And there are two targets. Now it's the second type, so there are two targets: antigen and the cell. I moved the camera because I was burping. The third type is the I in acid is the immune complex one. So the immune complex one is where there is deposition of the immune complex, which are formed of three parts: antigen, antibody, and complement. One distinction in here is that the second type usually happens on the cell surface, and the third type is where there is deposition in the cell, in the tissue, right? Of the antibody complex, antigen antibody complement complex. So the D is the last type, fourth type, D for delayed, right? So there are no antibodies, it's a delayed T cell response. Now, quickly, what we are going to do is we're going to go over this table, this lovely little table, and then we'll explore all of the hypersensitivity reactions individually. I'll have a sip of water. And if you feel like, oh, this guy could do it faster, or this could be better with editing, I would love to have an editor or someone to edit things, because that's not my cup of tea. I tried it, did not work out. All right. Oh goodness, I'm just hoping that I don't speak too loudly into the mic. Also, one more thing: why am I wearing earphones? I'm not listening to anything. I'm not hearing anything. So, uh, that's one thing out of my ear. It implies that there are multiple things in my ear. I was checking if there was like an alarm or something. No, I don't have any alarms after 9. Enough fluff, another talk. So type 1 is when, as I said, anaphylactic. It happens immediately, so it happens within minutes. Wait a freaking second. We don't want spell check. This is better. I'm sorry, guys. I'm so sorry. I'll try to make sure that the spell check is off. It's just that I'm a little nervous. I'm a little nervous fellow trying to teach you about hypersensitivity reactions. So IgE-mediated release of histamine and other mediators. This happens from mast cells and basophils. The cells involved are the mast cells which release IgE. The cytokines here are histamine and leukotrienes. Examples are allergic rhinitis, asthma, food allergies, drug allergies, insect sting allergies, atopic dermatitis, and anaphylaxis. The reason that some parts are highlighted in a golden hue is because they were previously asked in an exam that I wrote, and now you have to remember them because it's nice and it's cool to remember things. It's type 2. The type 2 acid C cytotoxic. Type 2 is when the reaction happens usually within hours to minutes. Yeah, hours to days. Boy cannot read from the screen. So here it's an antibody-mediated cytotoxicity, wherein the antibodies involved are IgG and IgM that leads to cell destruction via complement activation or phagocytosis. Phagocytosis, phagocytosis, phagocytosis is when immune cells go and eat other things. So they're in like the cells that we see are NK cells, which are the natural killer cells. Also, by the way, if I'm unable to get through anything, like if I'm unable to understand something here, I'm going to Google it on the in the video. I'm not going to like take a break, re-record it because I'm not dealing with none of that. Okay, let me check if the recording is still happening. Cool, we're 6 minutes in and we're still on the first page. All right, back to the yeah. So you will not be able to see when I'm changing things because that's how I like it. So the cells involved are the natural killer cells and the complementary system, and the antibodies involved are IgG and IgM. Here, the cytokines involved are C3a and C5a. By the way, my head. Oh, you saw the page for a second. My head over here might be covering up things. I'll try to make sure that it doesn't usually happen, but if it happens, I apologize. You got to see me as well, even though I don't get to see you. So, me to my ex. But when I sent her unrequited photos of myself, just my face. So type 2 is like seen in autoimmune hemolytic anemia, drug-induced hemolytic anemia, Goodpasture syndrome, immune thrombocytopenic purpura, and myasthenia gravis. So let's move on to the type 3. Type 3 is acid I. Oh my god, I forgot. Well, we can check it again, immune complex. So, see how good my memory is. Usually it happens within hours to days. I should have written it better, but it's fine. So here, as I said, there's a formation between antibodies and soluble antigens, which leads to complement activation and tissue inflammation. This is conducted by the neutrophils, like an important role. The cells that play an important role here are the neutrophils, and the antibody involved is IgG. G for grandma. One silly thing. So that you have IgG and IgM. The way that I remember these are, M for mom and G for grandmother, something like that. So the thing is that as your mom is like working around the house and doing things and stuff, but your grandmother used to do stuff, and this is where I show my misogynistic side. Basically, IgM are released when an infection is actively happening, and IgG are the memory kind of stuff, right? They hold memory of the disease that happens. So if we check IgG for any disease, any infectious disease, we are looking to see if it happened in the past, right? But if IgM is positive, then that means the immune system is actively still trying to fight the infection. So where is it seen? It's seen in serum sickness, SLE, systemic lupus erythematosus, rheumatoid arthritis, post-streptococcal glomerulonephritis, polyarthritis nodosa. By the way, if I get to have time, I'll go over all of these diseases individually. I love I don't know, rheumatology. Like, this is part of rheumatology. I love it. But we'll see if we have time. I've also got to prepare for my this thing PG and stuff, and I'm not doing much. So anyhow, type 2 lepra reaction, which is, oh, the one fun thing. Am I confusing this? Well, remember this, the lepra reaction thing, remember that. We'll talk about leprosy later on. So, borderline lepromatous leprosy, and then henochulon purpura, Arthus reaction, and then reactive arthritis. So we go to the fourth type, acid D delayed. So it happens 48 to 72 hours. So this type is mediated by the T cell, leading to delayed hypersensitivity. So the T cells involved here are the CD4 plus. I show my medical ignorance, CD4 and CD8 T cells. And there are fun fact, as if it's fun, there are no antibodies involved in the type 4. Here you have interferon gamma, INF gamma, and interleukin 2. Uh, is this interferon gamma? Let me Google it for you. It's good that you don't see my screen, otherwise you'll be like, it's good that you don't see my screen, otherwise you'll be like, what the hell? What the sigma? God, once again. Hmm. Interferon gamma. I was correct. Why did you doubt me? You shouldn't doubt me for a second. Danish is always correct. Contact dermatitis is an example of type 4 sensitivity, wherein helper T cells are active. The tubercle and skin test, the Montauk test, is done not using this, is based on this principle. There's allergic contact dermatitis that happens from topical medications, granulomatous reaction, delayed type hypersensitivity to certain drugs. So what we are gonna do is go to the first type again, and we're gonna read through this. I hope you're not bored by now. One thing I want to tell you is that here you have two parts, and we're gonna go through the second part because the first part is full of text and blocks, and this is a little bit more interesting, but we'll read through the definition first. So the type 1 hypersensitivity reaction, also known as immediate hypersensitivity or allergic reaction, is an exaggerated immune response triggered by allergens. IgE, as I said, immediate onset allergic reaction. So all of these things happen: rhinitis, asthma, food allergies, to shellfish, fish, penicillin, insects, sting allergies, allergic to conjunctivitis, atopic dermatitis, eczema, all of these eye related conditions, which oh my god, you really want me to like Google them and like, tell you all the sure. What the hell, why am I not able to? All right, so the first one is seasonal allergic conjunctivitis, and then we have perennial allergic conjunctivitis, vernal keratoconjunctivitis. This one is a little important because people ask questions about it. By people I mean examiners. Atopic keratoconjunctivitis, and then you have giant papillary conjunctivitis, and all of these are just conjunctivitis. Just remember, conjunctivitis happens due to allergy. Can happen due to allergic keratitis and anaphylactic reactions. So there are two phases: sensitization phase, where there is allergen exposure that simulates IgE. So allergen goes to APC, the antigen presenting cell, which presents to uh, T helper cell, and then that leads to release of interleukin 4, which leads to release of IgE, which binds to mast cell. Now like once it happens, uh, wait a second, we should stop here. So in activation phase, re-exposure to the allergen causes cross-linking of the IgE bound to mast cells and basophils, triggering degranulation, right? So re-exposure, the IgE is cross-linking, and there is degranulation. Now from here we can read through this, but I prefer this one because this is a little bit more interesting. And the reason that I have two types of these is because like the first type I did it for my exams, and this type I'm trying to be a little more succinct. Wonderful accent, Danish is there. That was good. So, phases, sensitization phase. As I said, allergen, antigen presenting cell, TH cell activation, and then TH cell interleukin 4. Then B cell switch to IgE. Then IgE binds to FC. What the heck? What is that symbol? RI on mast cells and basophils. Now, when there is a re-exposure with a shocking dose, The allergen binds IgE, which leads to cross-linking, and this cross-linking leads to granulation of the mast cell, wherein we see two types of mediators, primary and secondary. So uh, now we'll look at the types of mediators. I'll put the screen a little bit here. So the primary types which are already formed are histamine, heparin, serotonin. What the sigma? You're gonna unsubscribe to the channel. Histamine, heparin, serotonin, ECFA, and CFA proteases, which leads to vasodilation, bronchoconstriction, and itching in the patient. Yeah, and then the newly formed ones are leukotrienes, prostaglandins, platelet activating factors, bradykinin, cytokinin, interleukin 1, and tumor necrosis factor alpha, which lead to smooth muscle contraction, vascular leak, and chemotaxis. Now, as we talked about the common types of allergens, could be food, pollen, drugs, dander, insects, in venom, like all of these. Just read it on the. It's on the screen. No, I'll just read it out for you. Foods like nuts, eggs, seafood, milk, drugs like penicillin, sulfan, salicylates. The thing is, you read all of this stuff and you don't have to answer it orally, and you just write out in the exam paper, and then patients come, you just write it on a prescription pad, and that's it. So you, well, environmental stuff could be pollens, dust, and animal dander. Timing 2 to 20 minutes. Late phase could happen because of cytokine recruitment, right? So what do we see? If it's a systemic involvement, there is hypertension, bronchospasm, urticaria, angioedema, GI upset, right? As we discussed the symptoms. If it's local and skin, you'll have urticaria. I should have attached the photo. I did not attach the photo. I'm sorry. This is sad. Can we get 1,000 likes? Let me let me see if I can find a photo. Like, this is how we are gonna do. We are making the video in real time. Urticaria, urticaria, yippee, yippee. So the one thing that I like to do is I like to think about these as my running notes. That is, I keep updating them while I'm working on them. Yeah. So I want a good image of urticaria. This is a good one, right? You must be wondering why am I still watching this video? And fair enough question. Embedding the image, yes. So you see it now, I suppose. Should I put in the image for atopic dermatitis? I'm not gonna do that. That's not what I am here to do. Like, you can Google it yourself. You don't need me for that. But because you have been such a good person today, I will try to get it for you. Yeah. That's the reason I'm trying to teach here and not going to singing. I don't sing so well. Da 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 da. Atopic dermatitis. God, I have a feeling this is not gonna work out well, but I have a feeling that I'll keep doing it because I'm a little crazy in the head. No, I'm just kidding. So, urticaria, wheal and flares like this, and atopic dermatitis, which is going to be like this. For urticaria, you could give something like Levocet, and it will reduce the. Well, we'll get to the treatment part anyhow, Will, so I should. So, in eyes, as I said, allergic conjunctivitis, other forms. Respiratory symptoms could be asthma, allergic rhinitis, and an exam favorite is ABPA. That is aspergillosis bronchopulmonary asthma. Did I get it right? Did I get it right? Guys, if I get it right, you have to donate 5 rupees in the chat. Just 5 rupees, guys. It's allergic. Ah, shit. Oh, okay. So the full form is allergic oh god, I just mixed it up. It's not asthma. God save me. It's this thing. Allergic bronchopulmonary aspergillosis. I apologize. But now you know, and now I know. So, and GI symptoms could be food allergy and vomiting. Now we are going to look at special entities. What the reason that we are doing this is because exam, and they could ask you these things in exam. So ABPA. Also, by the way, you don't have to donate 5 rupees because I got it wrong. You have allergic bronchopulmonary aspergillosis. Yeah, in here you find type 1 and type 3 acid. A is anaphylaxis, the fastest type. 3 acid. I What is I? What is I? What does I stand for, guys? mm, I forgot myself. Shit. No worries, no worries, that's the reason we have notes. I stands for immune complex. Great. Don't look at the link there, guys. It's not good for you. Well, if you have, probably I'm gonna change it. I'm gonna make sure that no one is able to see the site. I'm just kidding. We'll talk about it later. So, hypersensitivity pneumonitis. Oh, by the way, we'll just do this. The third, yeah, I was for immune complex. So this is we've seen in fungal hypersensitivity in asthma. That's our cystic fibrosis. That's why I was like, trying to be here. So hypersensitivity pneumonitis here, it's a little bit confused usually. Like people get confused. It's usually caused more by the fourth type, which is D delayed, and then I immunocomplex. Organic dust is like causes this, so it's not type 1. Another one that we have is tropical pulmonary. Also, God bless me. What the sigma? You guys are gonna leave this channel, I'm sure. Uh, yeah. So hypersensitivity. Sorry, tropical pulmonary eosinophilia. So this can be found in Bucellary bankruptcy. Bucellary bankruptcy. I think that's a organism. And here we have type 1, and then Casori test hydrated, Echinococcus hydrated disease, right? The cysts. So here type 1 is found. So that's important. um, then you have skin prick test, where sorry, diagnosis. Yeah, guys, diagnosis. First you have the skin prick test, where you have in vivo allergen response, that is histamine release. Then the RAS, that is allergen specific IgE test. And then RIST. I will not google the full form of these. Just kidding, I will. Guys, the reason that I google all these things is so that you know and you realize that I as well don't know everything. Just kidding, I know everything. But yeah, where do I put this? Can I put this here? No, it was such a cute emoji. No, emoji, stay here, stay with me, emoji. So what the sigma, where did it go? I The radio allergosorbent test, and the other one is radio immunosorbent test. Now these are not so commonly used, but now anyhow. So eosinophilia, like on WB, on like CBP or CBC, you see eosinophilia, that is common in discharge and in blood. And then serum IgE, that is seen increase in allergies, helminths, and hyper IgE syndrome. Hypersensitivity syndrome, yes. So we'll talk about the treatment, yeah. So firstly, eliminate the triggers. Try not to be there. If you get the triggers, start with the first like pharmacological therapy. You can give something like antihistamines. Cetirizine is H1, Antidin is H2. I hate when people use Antidin as a means of acid control when we have pantoprazole, the PPIs. So always prefer PPIs for antihistamine for acid suppression. Then you have mast cell stabilizers like sodium chromoglycate, which is used as a prophylactic, right? And then you have other drugs, combo drugs like azalistin and olopatadine, which is the drug of choice for allergic conjunctivitis. Then you can use steroid if it's moderate to severe, sorry. And then you have epinephrine, wherein you see like the dose being 0.3 to 0.5 mg, given intramuscularly for adults. That is the drug of choice for anaphylaxis. Then you have immunotherapy, desensitization. which is allergen specific, and then there is an anti-IgE biologic called omalizumab, which is used in severe and asthma or urticaria. Now, there are some experiments that you need to know about. There was this thing called the PK reaction, which is about the passive transfer of allergy via serum, right? And then you have the Schultz-Dale, uh, like all of these reactions, like these things, these experiments involve type 1 hypersensitivity, which is the smooth muscle contraction. And then there was this other one called the Theobald-Smith experiment, wherein there was like study of anaphylactic shock in guinea pigs. You can forget this; it's not so important. Maybe not. Depends on what exam you're writing. So common mistakes, you should avoid confusing between IgE, that is type 1, and IgM IgG antibodies type 2. So that is one thing. Another thing, hypersensitivity pneumonitis, you should not like label it as type 1, is type 4 or type like more than type 3. And then forgetting about late phase symptoms and mediators. All urticarias are allergic. No, not always type 1. So some high yield facts: type 1 is first and fastest. Think IgE, Marshall system, epinephrine, a drug of choice for anaphylaxis, and allergic bronchopulmonary aspergillosis. What happens there? Type 1, type 3. Skin prick test is the most sensitive in vivo, and histamine is the preformed one due to leukotrienes forms later. Yeah, but they're stronger. Oh goodness, we have studied so much, guys. We are the most studious bunch in the whole galaxy. I don't even know if I have like enough storage. It's 26 minutes already. We are gonna go back to this, and if we are gonna off this. Yeah. So type 2 is a reaction. Type 2 acid C is for complex. Complex. Yeah. C is for complex. Guys, you need to answer me, guys. If you keep doing it like this, it's gonna be difficult. Cytotoxic. That's why I hate mnemonics. But hey, the more you read, the more you know, the more you understand, and the more and more type 2 hypersensitivity is mediated by antibodies directed against antigens, right, on the surface of cells or tissues. As we talked about, it happens on the surface of cell, as opposed to the type 3, which happens on inside the tissues, yeah, in on the tissues, like in the tissues, in the cells. So the mediator here are IgG and IgM, which are against cell-bound antigens. So we'll just look at this little bit, and then we'll look at the examples. Yeah. So processes here are opsonization with plus phagocytosis. Opsonization is that the complement particles go around, make tiny little holes in the cell wall, and then phagocytosis is where that the broken cell wall is eaten. The lysis, okay, complement mediated lysis happens, and ADCC. What the sigma? What is ADCC? What the sigma? What the sigma? So what is ADCC? Oh, antigen dependent cytotoxicity. Oh goodness. Antibody dependent cell mediated. Okay. Okay, this is the full form. And then there is receptor dysfunction, where there is activating, for example, in gravis, and blocking in myasthenia gravis. So, like here, IgM or IgG antibodies target self-antigens or foreign antigens on cell surfaces. Yeah. And then what happens is that, like, these cells are then destroyed by the means of complement activation and phagocytosis, sorry. And we'll not look at all this because we've got some much better stuff here to do. Yes. So type 2 involves antibodies, primary IgG and really IgM targeting. This is just leading to cell destruction, and so these are classified again until under gel and Coombs. Yeah. So how does it happen? So here the main antibody, immunoglobulin is IgG, which binds to the cell surface antigens. Yeah. And what happens is that then the complement cascade is activated. This cascade leads to the formation of membrane attack complex, right, which includes C5 to C9 cytokines. That leads to cell lysis. So additionally, other components are also found like C3A and C5A, which are anaphylatoxins, which cause inflammation via the chemotaxis of neutrophils, and C3B and C4B, which are opsonins, which enhance the phagocytosis. Then the next thing, antibody-dependent cellular cytotoxicity, ADCC. The Fab part of the immunoglobulin Z binds antigen on target cells. Yeah, and then there. Okay, I'll just show you an image of IgG. Imagine you don't know what antibodies are. Couldn't be me. Couldn't be you either. And if it is you, don't worry. You'll know what an antibody is. So it's basically talking about what it's basically talking about the this thing. This is an antibody. There are sections. There is a Fab section and there is an FC section. Yeah. So Fab section binds to the antigen, binds antigen on the target cell, and FC section, this one, binds to interacts with the FC blah, 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 blah. FC section, the region interacts with the FC reactors on natural killer cells that release perforins and granulomatous, which leads to the apoptosis of the target cells, right? These target cells are infected cells, tumor cells, parasite, and transplanted tissue. Now you see the last part, which is the antibody-dependent cellular dysfunction, ADCD. Antibodies bind functional cell surfaces, altering their signals. So, for example, it could be simulatory that they activate the receptor. For example, in Graves, inhibitory, where they block the receptor, such as in myasthenia. So, antigen type. So, fixed antigens can be on where cell membranes, basement membranes, extracellular matrix. They may be self, they may be foreign. For example, drug haptens or allo antigens, which is due to transfusion and graft. Right, and the onset is 5 to 8 hours, and they're still classified as immediate hypersensitivity, but well, they're slower than type 1. So we're going to look at the classification. Before that, we're going to have a sip of water because I'm thirsty. So we're back. Type 2 hypersensitivity. We're going to look at the systems, like look at it through the systems that it affects. Yeah. So first we have a condition called autoimmune hemolytic anemia. So here what happens is that the autoantibodies bind to red blood cells antigens, which leads to complement-mediated lysis or splenic clearance. We'll talk about AIHA later on as well. I mean, in a different video, but this is a clear enough explanation, I think. Then there is drug-induced hemolysis. For example, drugs like penicillin act as haptens on red blood cells, right? And there is this is an exam favorite, RH incompatibility, the hemolytic disease of the newborn. Here, maternal antibodies are formed against fetal RH factor, which then cross the placenta. Then you have something called the transfusion reaction, where pre-found IgM or IgG antibodies against ABO antigens lead to intravascular hemolysis. Then you have heparin-induced homo. Then you have heparin-induced thrombocytopenia type 2, wherein antibodies are found against heparin platelet 4 complex that leads to platelet activation and thrombosis. Now, looking at renal and pulmonary stuff, you have Goodpasture syndrome, which involves lungs and kidneys. Where and what else? Let me just get it for you. I don't need to know now. No, now if you love me again. So where does it happen? So it's a pulmonary renal disease, yeah. So it leads to leads to rapidly progressing what do you call it? Progressing glomerulonephritis, yeah, and diffuse alveolar hemorrhagic what? God knows. I'll just paste it here. Oh, bro, what? What are you doing, man? Where are you? Where's your mind? Huh? It's your heart. Diffuse alveolar hemorrhage. Right. So here you have IgG against type 4 collagen, type 4 collagen. Okay, by the way, later on we'll talk about collagens, types of collagens and the diseases found there. It's an exam favorite. But now, for now, good pasture, type 4 collagen, which is found in glomerular and alveolar basement membrane. Neuromuscular diseases like myasthenia gravis, wherein the antibodies block the acetylcholine receptors, acetylcholine. um, I, I don't know. I don't know, guys. Sometimes it just happens. Antibodies block acetylcholine receptors at the neuromuscular junction. And then in Graves, what happens is that in Graves' disease, that was such a grave mistake. Indeed, it was. Yeah, there are antibodies that stimulate the thyroid stimulating hormone receptor that leads to thyrotoxicosis, right? Dermatological, you have pemphigus vulgaris. I should have put an image for this, but this is not dermatology, guys. This is not dermatology. You're just getting to see my face, my beautiful face, and I think that's good enough for most people. And if it's not, I'm sorry. Please put it in the comments, and later on I'll put in images in this video and update it. So pemphigus vulgaris. So here you have IgG against the desmosomes, which leads to intraepidermal blistering. This is also an exam favorite question. We'll talk about like the pemphigoids and the phymphus later on. Then you have bullous pemphigoid, wherein IgG against hemorrhosis, which leads to subepidermal blisters, right? And then you have ocular mucous membrane pemphigoid, wherein there are autoantibodies against basement membrane in the conjunctiva. Cardiac, you have rheumatic fever, where there is cross-reactivity between the M protein of Streptococcus myogens and the cardiac myosin, right? Because they are similar molecular mimicry. In vascular type, you have hypersensitivity vasculitis, where immune complex form and antibiotics attack vascular endothelium. And then transplant, you have hyperacute graft rejection, where preformed antibodies destroy graft endothelium and thrombosis and ischemia. So leading thrombus and they destroy thrombus and ischemia. Sorry, I just a little. I was just a little confused. I'll just look through here once. No, guys, all good, all good. I just wondering about something, and now I'm not wondering. Okay, guys, so let's look at the diagnosis. These are the diagnosis not for type 2 hypersensitivity, of course, but like for the diseases in here, yeah. So you have direct Coombs test. So the Coombs test has two types, direct and indirect. Uh, Wow, like just as if it's not on the screen. So direct Coombs test is where you detect antibodies bound to red blood cells. This is useful in the autoimmune hemolytic anemia. Yeah, and then indirect is when you just look at if there is any antibodies, right, in the blood. It's used in prenatal testing and to check blood compatibility. Then you have ELISA, which is the name of Hamilton's wife's sister. Um, enzyme linked to immunosorbent assay, which is used for the antibody detection in Graves' disease, myasthenia gravis. And then you can do histology and biopsy, wherein you'll see immunofluorescence showing immunoglobulin G and C3 deposition in pemphigus or good pasture. I'll upload images of this on the separate video about the disease itself, because if I do everything in here, this video is going to be longer than it already is. Treatment: autoimmune hemolytic anemia. You'll give corticosteroids and immunosuppressants. In RH2 incompatibility. Sorry, you give immunoglobulin prophylaxis to the mother. In induced thing, yeah, used to have a pattern. You use direct thrombin inhibitors. In Graves' disease, you give antithyroid drugs like metamizole. By the way, Graves' disease is also quite interesting. We'll do a video about that. Beta blockers and radioactive iron, myasthenia gravis. You can give acetylcholine inhibitors like pyridoxine, pyridoxine, guys. That's a name we all know. It's a home brand. Immunosuppression is one of the ways. Plasmapheresis is another. Then in pemphigus vulgaris or bulbous pemphigoid, we give systemic corticosteroids. And then finally, transfusion reaction. Stop the transfusion, guys. We support pure hydration and monitor pre-and care. Halfway through. So do not confuse type 2 with type 3. Type 2 antibodies are directed against fixed antigens. Type 3, they are targeted against soluble antigens forming immune complexes. Yeah. Ah, does make much sense. Does it now? Doesn't it now? It does. I can see you through your phone or mobile camera, and yeah, that's how you make people paranoid. Autoimmune diseases can overlap other mechanisms. For example, SLE has type 2, type 3. Hyperacute transplant rejection is purely a type 2, right? Unlike acute or chronic. So you just put in the transplant thing, hyperacute, it's type 2. So demonstration of that. Coombs test is central for clinical confirmation. So high yield one-liners. Direct Coombs test, what it does directly, it sees if there are red blood cells, right? Indirect one, it detects if there are any floating red blood cells. So direct one is used in autoimmune hemolytic anemia. Hyperacute graft rejection is type 2 caused by preformed antibodies. Then Graves disease and myasthenia gravis, example of antibody-dependent cellular dysfunction. The final one, Pemphigus vulgaris targets desmosomes, and bulbous pemphigoid targets hemidesmosomes. So you could remember it by vulgar blisters are in the middle. The fuck is that example? God knows. If you get it, if you get it, you get it, guys. You just had to be there. You just had to be there to get it. Um, I just am wondering, if anyone is even watching this at this point because it's just been so long. Yeah, and I'm cracking jokes like it's a comedy show. Type 3 hypersensitivity acid I immunocomplex. See, I'm learning things too. So, no, it's actually on the screen. Type 3 is immune-mediated response characterized by formation of antigen-antibody complexes that deposit in various tissues, leading to inflammation and tissue damage. So, the mediators here are immune complexes, AG, and mainly IgG plus complement. Yeah. So, do you hear that? I heard something, but I don't really care right now. So mechanism is there is excessive antigen, and then there becomes a circulating complex because the antigen antibody get together, and these deposit in the tissues, right? And then there is activation of the complement, which leads to C3a, C5a opsinogens, if you remember from the previous one. Which attract neutrophils, which leads to enzyme release and inflammation. So this happens like the timing is either 2 to 8 hours or it's quite delayed. Yeah. Examples: post-streptococcal glomerulonephritis, polyarthritis nodosa, Arthur's reaction, serum sickness, Arthur's reaction, localized. I should delete that. Post-FGN, same repeated. SLE, RA, rheumatoid arthritis, PAN, again polyarthritis nodosa, and type 2 lepra reaction, and then serum-like syndrome. Yeah. And then we'll look at this part, the below part, which is the better part. So there is this happens due to excessive antigen antibody complex, which gets deposited in the tissues. It's mediated by IgG mainly and IgM rarely, right? Reacting with soluble antigens, which are the antigens which are freely present in the blood. So here primarily IgG, and IgM, or rarely IgM. So antigen are soluble, could be exogenous like virus and bacteria, or endogenous could be DNA. These complexes are formed in circulation and deposited in tissues like joints, kidneys, and vessels. The effector cells are neutrophils, which are attracted by complement C3a, C5a, opsinogens. The complement role is when it gets activated, there's inflammation, chemotaxis, and opsonation. So how does it happen, guys? How does it happen? So first, as I said, immunocomplex AG plus AV. I'm just now realizing it's antigen and antibodies. Such a smart tutor you've got for yourself. Great. Thanks for watching this video. Hit that like, subscribe button, and press the bell notification for a video in 10 years, because I'm not gonna post another video. I'm sorry, I'll post another video. Just kidding. So there is deposition in vessel walls, glomeruli, joints, and then there is activation of C3a and C5a and C3b and C4b. God, I was mistaking them. So C5, this one is for chemotaxis, and this one is for opsonation, opsonization. Goodness, this is a long video. So then you have neutrophil deregulation, where there is a release of lysosomal enzymes and reactive oxygen species ROS, which leads to tissue damage. Yeah, and then the clearing happens where via C3b mediated transport to spleen, which is inefficient if the complex load is high, because the spleen gets like just keeps collecting things. Yeah, so a mnemonic could be IC craft, like this one. Immune complexes, circulation complement, chemoattractants, release enzymes, acute inflammation, failed clearance, failure. See, that's a port menu I'm making, and tissue injury. Now the timing, general reaction is immediate, 2 to 8 hours after exposure, and then there is serum sickness, which is delayed 10 to 15 days, and then there's something called the Arthur's reaction, which can happen within hours. Yeah. So what we'll do is, we'll wait a second. Wait a second. Did we talk about the things that we want to talk about? Yeah, we talk about one thing I'm searching for is we did not talk about Arthur's reaction, guys. So we'll just put in a few points about it. Yeah. How does that sound? Does that sound cool? And I forgot to. God bless me. I'm such a kind soul. Smiling. Just smiling. Let me check if the recording is still happening. Imagine if it just stops recording because oh goodness, it's an hour long. God, man, no one's gonna watch this video. Hmm. All right. We are getting back, guys. Don't worry. Don't worry, princess. I'm here. So there is what happens is that it happens after intradermal subcutaneous injection of antigen that the previously sensitized person into a previously sensitized person. Yeah. With high circulating levels of IgG specific to that antigen. It still doesn't make sense in my head, so I'm just gonna re-look at it. Oh. So the thing is, the person should have been previously sensitized, right? So, for example, it has happened a couple of times already that the antigen has been given to the person. It's like that. Wow, I'm so good. I should make a YouTube channel. Um, So the test that we can do, what complement cell? Complement levels where there is decrease of C3 and C4 and decrease of CH50. ESR is elevated. CRP, or one thing, ESR and CRP, erythrocyte sedimentation rate, and C-reactive protein. Yeah. So how I like to think about this is that the reactive protein is something which happens in a reaction happens quick. So if any condition goes wrong, the C-reactive protein will be like the first one to show up. And then you have erythrocyte sedimentation rate. Sedimentation takes time. So ESR will show up later, like the increased, like ESR is shown later in a condition, something like that. Yeah. And CRP is the first one. ANA or ANCA, which is positive in autoimmune cases. Immunofluorescence, which can show granular bumpy serologies, hepatitis, like serologies, ASO titers, and etc. Coombs test negative helps us differentiate from type 2. Treatment will remove the trigger, and again, it will depend on the condition exactly. So NSAIDs, you can ask for flowers, ask it for hours, telling all the bluebirds, the blue and cool birds, pretty little baby. I'm so in love with you. Where else are you gonna get like your guy singing for you? You're never gonna get something like this from any other YouTube channel where they edit everything and they make like really efficient and efficacious videos. So uh, then you can give systemic corticosteroids for moderate to severe cases, and there is something called plasmapheresis, wherein you filter the plasma, yeah, where there is severe immune complex overload. Fun fact: my ex had lupus nephritis. I miss her so much. Please come back to my life, my ex, my dear ex. I miss you. Imagine she watches this video. Out of the two people who watch it, imagine if she watches the video. It's gonna be funny. This disease-specific therapy like immunosuppressants for SLE. Now we are gonna look at the example serum sickness. Serum sickness is when you introduce foreign serum proteins like antitoxins or monoclonal antibodies. So these things that we'll see are fever, rash, anthalgia, lymphadenopathy. SLE, you'll have DNA and nuclear antigens. And the signs are malar rash, nephritis, arthritis. These are just an overview. We're going to go into detail much later. Rheumatoid arthritis, which I already have a video of, which I'm not happy with. I'm not happy with anything. That's the secret of being sad. Early phase, you have rheumatoid factor plus IgG, which act like the antigen, and IgG acts like antigen. Wow, such a great discovery. Joint destruction is found. Polyarthritis nodosa. Herein we'll find this thing, hepatitis B surface antigen, which is kind of crazy if you think about it, because you think that hepatitis B is like this the condition that affects your liver, but in pan, that is polyarthritis nodosa, hepatitis B antigens are found, right? Crazy. And what we find in the condition is necrotizing vasculitis, yeah. And then you have IgA vasculitis, wherein you have IgA and antiglobulins and so what do we have? Antiglobulins complexes. Symptoms found are palpable purpura, abdominal pain, nephritis, and then you have subacute bacterial endocarditis, where you have fever, murmur, and Osler's notes. Endocarditis, Osler's notes. You must remember Jones criteria. Is Jones criteria for that? God bless me, because I surely can't. Oh no, I'm confusing. Oh no. So, but wow, no, Jones criteria is not used for this. Or is it? Or is it? Gentlemen, today we are gonna find the answer is no. It's not used for that. I forgot the criteria, but you will not, because I'll help you. Oh, it's this thing is called B-med. You must be wondering what the hell is he looking at the screen, and I'll not keep you in so much what do you call it, this thing, suspense. So Osler's notes, yeah. So B timer is, baby, please load. Oh yeah, it did load, sorry. So this is this, and there are some other specific questions about it which come up in exams, which I will talk about later because it's already been such a long video. So organ specific things that can happen in type 3 hypersensitivity are like PSGN, streptococcal glomerulonephritis. It's the most common cause of glomerulonephritis in children. We'll talk about all types of glomerulonephritis later on. So it affects glomeruli, and then there is what are the things found? So there is cola-colored urine, edema, hypertension, and then you have dengue-associated arthritis, which affects joints. So it's like remarked as post-viral reactive arthritis. Then you have nephrotic syndrome due to Plasmodium malariae, which is where you have glomeruli again been affected. So you find proteinuria. Then you have Katayama fever, which is schistosomosis, which is wherein liver and spleen are affected. And then this is due to the systemic response in systemic response to the eggs which are like laid there, yeah. And then you have African trypanosomiasis, where there is CNS involvement, and we see encephalitis and immune-mediated damage. So there is the points of confusion again. Hypersensitivity pneumonitis. We have three but usually they have usually 4 or the type 4 hyperacute graft reaction, type 3 we think, like, but more acute is type 2, like in some sources it's like that. And then Stephen Johnson syndrome, and 10 toxic epidermal necrolysis, type 4. Rheumatoid arthritis is mixed, type 3 is more dominant. uh, Erythema nodosa leprosum is type 3, and then the general one is no types. I mean, no specific type is assigned. So desensitization you can do, it's possible, but it's rarely practical in type 3 mediated diseases, yeah. And so we'll just look at the high yield facts. Type 3 is where you have immune complex mediated injury. Antigen is soluble in type 3, well, whereas in type 2 it's cell bound. The granular immunofluorescence pattern, if granular patterns from type 3, linear is from type 2. Important point. exam ready. You're now exam ready. SLE is a prototype of systemic type 3 hypersensitivity. PSGN follows streptococcal infection, not due to direct bacterial invasion. Yeah, goodness. Finally, we are done with hypersensitivity. I hope after this you don't want to read anymore. I'm just kidding. I mean, I don't want to read any more of hypersensitivities because we've done so well. So, the fourth type, acid D, is delayed. It has a delayed onset. So it's mediated by T cells and no antibodies. Yeah. And so we're going to go down directly, ignoring all this, and it doesn't involve, it's a part of this. So there are phases. Yeah, sensitization phase, so it's the initial exposure. So cells which are antigen presenting, like Langerhans cells, process the antigen and they present it to the T helper cells. Yeah, this differentiates into the T delayed type hypersensitivity cells, which is a subtype of Th1, T helper cell 1. This leads to the formation of memory CD4 and CD8 T cells. Now, when the person is re-exposed, the memory T cells are activated, which release cytokines, which include interferon gamma, which activates macrophages, tumor necrosis factor beta, and then interleukin 2, which leads to T cell proliferation, and then monocyte chemotactic activation factor, migration inhibitory factor, and then GM-CSF, right? So the CD8 toxic cells may directly kill target cells, and then when macrophages are activated, they lead to inflammation and tissue damage. So it's a delayed onset, 48 to 72 hours post exposure. Now the antigen here can be soluble or cell bound. Sources could include intercellular pathogens or environmental factors or even self antigens. Yeah. So we're just gonna wrap it up real quick. So like based on like examples, I mean based on like systems. Yeah, skin reactions. Who's gonna sing you this pretty after I'm gone? No one. And we need to get rid of the red markings. So you have contact dermatitis with poison ivy, nickel parathenium, erythema multiforme, which can happen in human simplex virus and mycoplasma. DRESS, this is an important syndrome, drug reaction with eosinophil and systematic syndrome symptoms, and scabies induced delayed hypersensitivity. We'll go look back at each of these diseases one by one. But I have like this thing as a wheel of topics. Whatever random topic it ends upon, I do that topic from now on. If you want a particular topic, just leave me a comment and I'll get back to that topic as soon as possible. Infectious granulomas include tuberculosis, wherein you see the tuberculin test. In leprosy, you can do something called the leprin test, type 1 lepra reaction, histoplasma capsulatum, and Candida albicans, and also Pneumocystis jirovecii, which is a very important fungi for HIV questions. Not HIV people. People with diseases don't care about fungi. Actually, no one cares about fungi except the mycologist, which are like some crazy people. I've never met a mycologist. Um, so mixed or debated. So rheumatic arthritis is type 3 plus type 4, hypersensitivity pneumonitis type 3 more than type 4, and then transplant and GVHD. So the chronic graft rejection and graft versus host disease are seen in type 4. So we're going to look at some of the distinct tests which use this type of hypersensitivity, which are based on this type of hypersensitivity. Yeah. Tuberculin is used to detect memory T cells response to the Mycobacterium tuberculosis. Patch testing is where you put direct contact allergens like nickel and hair dye to test. Lepromin test for cell-mediated immunity in leprosy. Montenegro test is used for leishmania infection, and lymphocyte proliferation assay is an investigational thing which is especially used for drug sensitivity. So as always, avoid the antigen. You can use topical corticosteroids in mild cases. Systemic for severe. Antihistamines can be used, but they are not so useful because type 4 is not mediated by antihistamines. Yeah, and immunosuppressants like methotrexate and retinoids in refractory cases. Thalidomide used in type 2 reactions, but type 4 is type 4 is a type 1 left reaction. Yeah, so desensitization can happen. It's difficult, but it's long lasting. So it's looking at let's look at the high yield facts. Yeah, it's the only hypersensitivity reaction which is not mediated by antibodies. The tuberculin test is a classic example. Contact dermatitis is the prototype for delayed hypersensitivity reaction. Granuloma formation is the hallmark, and type 1 leper reaction is the type of type 4 hypersensitivity reaction. Wow, wow, guys, we are finally done. Guys, let me just have a sip of water, and I request you to take a little break as well. Just relax for a bit. So, back to you guys now. If there are any mistakes in the video, and if you happen to catch them, or if I happen to catch them, what I'll do is I'll go to the comments and I'll make a pinned comment wherein I'll add all the mistakes, yeah, so that you don't miss anything. Other than that, I hope this video was interesting as well as informative. The reason that I just am deciding to do it in this form factor is because I want to make sure that I keep doing things and that it's not like I just don't end up just not doing anything. Yeah, if this is not the type of format that you like, if you have any suggestions, you can provide me the suggestions. But for I burped kind of again. But if you have any other suggestions, I would love to hear them. But for now, I'm going to be making videos like this. I hope that this style of videos resonates with someone, resonates with some people, because I enjoy like doing stuff like this. Yeah, because all that hyperproduction stuff takes a lot of energy, and at the end of the day, what happens is that right now, for example, we covered all types of hypersensitivity reactions with such detail. Yeah, I don't think I could have done it in such a manner if I had done all these things like I used to, like separating the audio and then producing the video separately, and then going through the script like 30 times. Like I do it like this because now I'm studying with you, and I hope you enjoy this. And if you don't, it's all right. Uh, yeah. So here's to more videos, and here's to restarting this project so that I'll have a catalog so I can apply for a teaching job later. Yeah. Bye bye.